so much for all those introductions. I'm really excited to delve into this discussion more deeply with you all. And with our first question, I would like to frame it and give you all a little bit of context to this global perspective of a question. So according to the New York Times Global Vaccine Tracker, all around the world, 905 million doses of the vaccine have been administered. But out of this 905 million doses, only 83% have been administered in high and upper middle income countries, while 0.2% have been administered in low income countries. This is coming on the heels of what global health activists and public health experts are calling a global vaccine apartheid. What we are seeing is that countries like Canada are purchasing the vaccine at 8.8 more times than needed for their population, and countries like the United States have bought up to 3 vaccine per shots per capita for their population, and the European Union is at more than 4 vaccines shot per capita for their citizens. So what we are seeing play out is, at the backdrop of this, is a lot of historical and systemic colonization, imperialism, and exploitation of some of these countries that have led to what we are seeing as globally a trend as the vaccine apartheid. And so here in Pittsburgh, or wherever you all may be, as we think of the lights at the end of the tunnel, as the vaccination efforts are gaining more momentum, and we're all excited for a return to normal, we are very cognizant of the fact that our return to normal as a globe will not be the same, because people in different parts of the world do not have the same access to the vaccines that some of us may do. And so my question to the panelists with this context is, how, in terms of the work you all do, how have vaccine distribution in Pittsburgh mirrored the global trend of vaccine apartheid that we see all over the world? And thinking of this in terms of like the inequities and the power struggles of the haves and the have-nots, the privileged and the underprivileged. So I'll leave that to you all.
I can jump in just to answer, I guess, where I stand with my work, but I think Pittsburgh is a really good example of this, in action, because Pittsburgh does, in a way, suffer a lot, and you can still see it in the neighborhoods from redlining, and it's very clear. And within that, there are many areas which are still so segregated, socioeconomic status and race and color, and I think with that, you have seen the issues within kind of this separation just grow larger with vaccine distribution, that for many of these communities, they're oftentimes, for example, the Latino community is in an area that is very hilly. It's not, easily accessible to as many places as, for example, if you're talking about Shady Side or Squirrel Hill or Oakland, that is very easily accessible. Whereas other places like Brookline and Brashear, it's not as accessible in some places. And I think with that, there has been less of a push and also just ability to offer vaccine and vaccination sites in these neighborhoods and in the area. And as such, it's more difficult for these communities to get the vaccine. And because Pittsburgh is so segregated, it kind of allows and creates this, I guess, separation where you have some areas where many people are vaccinated and it's a lot easier to get a vaccine than in others. In addition to that, I think this is more so looking at just getting a vaccine. Many of the sites are only open from a 9 to 5 day, and even for some less than that. And for those who aren't able to take off work, if they do, they'll get fired, or if they just can't, it has made it incredibly difficult to get access to a vaccine. And unfortunately, many of the I guess, people who are in this situation who cannot take off work are those either people of color or socioeconomic status being lower. And I think within Pittsburgh, that has become very clear within just in all aspects of medicine and trying to get out the vaccine and information.
Yeah, and this is Miracle. And to piggyback off what Ben was saying, we also know that the workers who are most at risk to contracting COVID-19 are Black and Brown workers, who are usually second and third shift workers. And so for us at One Hood, we've done like weekend pop-ups We've tried to like reach out and let people know when vaccines are occurring. But when we're also talking about like the capitalistic way that the vaccine distribution has gone, we also have to point out that when the vaccines were first hitting and they were distributed to neighborhoods, people were actually encouraged to leave their neighborhood and go to different neighborhoods and grab the vaccine, which actually meant those doses for particularly Black and Brown people were being given to people who weren't from those neighborhoods. And we literally saw people creating social media groups, creating Facebook groups, creating chains where they were literally getting their friends and family members to the point that the majority of folks were getting vaccinated outside of their own zip code. And so it's like very important when we're talking about hoarding vaccines and making sure that people understand the inequities that faces medicine. It is a very Pittsburgh case study because we're seeing that and like we're living that. And on top of that, we're also trying to combat um, vaccine mis and disinformation. And we also see where the doctors show up, where the doctors are sending information, what the traditional forms of communication are. And that also leaves out our communities. We had a program we have on Thursdays called Ask a Black Doctor. And we've been very fortunate that we've had some Hispanic doctors come on and they've talked about having to fight just to get stuff translated in different languages, and how even though we're supposed to be this multicultural like place where we're a city for all, British for all, even to get stuff translated is a fight. And so I think that all of the global indicators of health disparities are found here locally.
I mean, I work for an even more centered community, I guess you can say, because I work for the Hispanic community, but I focus on pregnant women because I work as a doula. Um, and I think that, I mean, I agree with everything that Miracle and Ben have said, that it has been very segregated, very, I don't know, like it's only been centered in certain locations, but also the lack of research, but there's still very little research for how it affects pregnant women. Hasn't been anything negative yet, so it seems that it's safe, but at least the clients that I'm working with, most of them haven't actually talked with their doctors about the COVID vaccine. So this population as is already feels segregated because they don't know if it's safe because they're not having these conversations with any of their providers. The vaccine's been out for quite a while and I've been to 2 or 3 births so far, and they ask them still, have you gotten your flu vaccine? But not once has there been any conversation about like, have you thought about the COVID vaccine? Here's a pamphlet, here's something. So we're seeing even less. And then you talked about translation, Miracle. Like there's so little information about pregnant women that it's going to be a while till we get something translated with information for pregnant women. So it's a whole different beast that we're dealing with in that community.
Yasmina, did you want to, before I say something, do you want to?
Sure, yeah. So I, at JFCS, work with a lot of different refugee and immigrant communities, and I think different communities have different levels of access to information and healthcare. And just, we knew this before, but the COVID pandemic has kind of, I think, making more people aware of the disparities in healthcare, and especially in terms of access to information and care. I think with interpretation not provided by a family member, with interpretation that is easy for providers to access, and providers are not relying on individuals to ask for interpretation. So we've seen this a lot in our work, trying to educate people about the vaccine, distribute the vaccine, and just in general, I think Maya has been a great partner and advocate for the use of interpretation as just kind of an expectation that providers need to know how to use interpretation and should be comfortable working with clients who may not speak English.
Thanks. Yeah, I mean, I don't have too much more to add. I agree with everything that's been said. I think, you know, a lot of the systems, I'm going to think specifically, I'm going to piggyback off of what Yasmina was saying regarding language for a second, language access. I mean, I think a lot of the systems were built not considering that people may speak a language other than English. And it's not just, I mean, at the vaccine clinic, it's really important, of course, to have interpreters, but it's also like registering, right, for the vaccine. I mean, if the website and the systems are not in any other language, like how are you going to even register? And then, you know, if you have a call center, but there's a long message in English before you can even get to an operator, like how are you going to how are you going to understand that? And I think that that's like what has really emerged to me doing this work, is just how all the systems were put in place, assuming that people not only speak English, but like are very, very tech savvy, like understand QR codes. I mean, you know, like really tech savvy, and that's just not right. It's not fair. And it continues sort of inequities. I do would want to just say though, that like, I have felt very lucky and privileged to work with so many community-based organizations like CASA, like JFCS that have put together so many pop-up clinics in communities. And you know, one of the things that I feel I'm really, really, really glad that we have leveraged the wisdom and expertise of community-based organizations. But I guess I'm saying this to anybody who may sort of, I guess anyone who wants to advocate for this broadly as well, that like I think as we do this and as we leverage our community partner experts as a healthcare provider, like we need to compensate them. Like I know that there are times where Yasmina and I were texting at like 10 o'clock at night about vaccines, you know, this is on top of all of our other work. And I think this also just elevates this idea that we are asking community-based organizations to support us as like healthcare systems, and we need to compensate them for that work and that time. And so I think that that's another really important issue that's emerged that, you know, through sort of vaccine distribution. So, yeah.
Yeah,